Started. Nope. Let's try it again. Okay, great. So contrary to my usual practice, because we have a packed agenda today, we're going to start on time. So welcome to today's conference. Just a few quick notes. Today is the Restore program. Next week, we actually will be off for the holiday. Happy July 4th to everyone. Hope you're doing something fun. And then on the 12th of July, we'll have Bartlett updates and cases. Please do come to that. I think there's a lot of changes that are happening on July 1st in Bartlett. Would probably be useful to have everybody here. Also, Dr. Agee will be giving a brief study announcement at that, and we'll do cases with the time that remains. And then on the 19th, we have an all-star cast coming for hepatitis B extravaganza. So please do join us for that. So then just a very brief moment of introduction. Today, we are very fortunate to have the Center Director and Program Manager for the Johns Hopkins Center for Substance Use and Infectious Disease Care Integration. And I just wanted to call everyone's attention to a really nice article. I will put this link also in the chat because you can't click on my slide, that describes a lot of the work that's being led by the two people who we are very fortunate to have with us today. Now, I could go on, but I will instead stop sharing and let them take over the sharing so that we can get into the meat of today's presentation. So welcome and thank you very much for joining us, Dr. Falade and Tracy.
Thank you so much for your kind words. And I think I'm sharing the correct slide set, right? It's so exciting to be here with everyone today to discuss really the approach to providing many of our patients who have substance use disorders with optimized infectious disease care. You all know me. Tracy, do you want to introduce yourself? You all know Tracy also, but
really happy to be here as well. Thank you so much, Eileen.
So we're going to jump in. I'm going to do some review of some data related to the effectiveness of some interventions that are currently available for substance use disorder care. Tracy will go through some cases, which we hope will illustrate how to use the many resources we have available for optimizing the care of our patients living with HIV or with serious infectious diseases. And then at the end, we'll talk about some upcoming opportunities to further improve our ability to provide care to this very vulnerable patient population. And so this is the title of our presentation. These are disclosures. And at the end of this talk, I'm hoping that everyone will feel comfortable discussing the negative impact of substance use on infectious disease outcome, feel comfortable describing evidence-based interventions to treat opioid and alcohol use disorders, and also feel more comfortable using the substance use and HIV care integration resources available at Bartlett, at Hopkins, and at Bayview. And so this is an ID meeting. Why are we talking about substance use? Anyone that has read the news lately knows that we have a national opioid epidemic, and Baltimore is hard hit. Rates in Baltimore of overdose death significantly higher than the national average, and it's our patients, older Black men in their 50s to 70s that are hardest hit. And this is all driven by fentanyl. We continue to have the drug supply infiltrated with fentanyl. In the last year, we have had over 100,000 overdose deaths. These deaths are avoidable. We also have had an increase in infectious diseases, hepatitis B and C. And this substance use epidemic is also driving ED visits and hospitalizations. The good news is that we have evidence-based interventions that can reduce the harms of substance use. In particular, we have really good interventions for our patients who are using opioids. Medications like buprenorphine, methadone, extended-release naltrexone, and extended-release buprenorphine decrease illicit use of opioids, decrease morbidity and mortality. They reduce infectious disease transmission, improve infectious disease outcomes, including higher rates of hepatitis C treatment and HIV viral suppression, and have been shown to be cost-effective. Other interventions, such as patient or peer navigation, have also been shown to reduce ED visits and hospitalizations and readmissions. I'm going to show some data which I hope will illustrate how this evidence-based interventions might impact our patients. So the first plot you see is from observational cohorts where they followed people who had been randomized into a study of buprenorphine or methadone versus no treatment for 60 months. So that's 5 years. And the thing I'd like to point out is, so the top plot shows you people that are not getting any treatment, no buprenorphine or methadone. And then the lower plots show patients getting buprenorphine in the lighter, I think those are squares, and then people getting methadone in the shaded circles. And so what you see is that those that are not getting any medication across the 60 months clearly have much higher estimated days of opioid use per month. You see that those rates go down over time, and some of that is the burnout that we see in people who use drugs. But I think what I'd like to point attention to is that we do see significant reductions in estimated days of opioid use per month early, right, in the period of initiation, but those rates don't magically go to zero, right? And so the fact that we're starting patients on medications does not mean that we should expect that our patients will become immediately abstinent. And so, let's reduce pressure on ourselves and not get disappointed when we don't see negative urine toxins all the time. And then I think the other thing to note is that it really takes about 5 years for majority of patients to get to a place where they are truly stable, even when they are on medications for opioid use disorder. Now, here are the percent of participants that remained in the study. So were retained on their medications. So we see that, at the beginning, everybody was getting either methadone or bup, but majority of patients over time do not stay on these medications. This is part of the natural course of the disease. And so there are other things that we do need to continue to think about to support our patients who are started on these medications, either to remain on these medications or to explore other sources of recovery support. I'm going to switch gears and talk about injectable buprenorphine. So this is a long-acting medication. For some patients, it's an opportunity to not have to be reminded about their opioid use disorder every day because they can get an injection once a month. This is a result from a randomized blind placebo-controlled study where individuals at 36 sites in the US were randomized 4:4:1 to injectable bup at a 300 milligram dose for the first dose, and then 300 milligram doses monthly thereafter, or 300 milligrams for the first dose and 100 milligrams monthly thereafter. These are the two curves, and then placebo or individual counseling. Again, we see in this very rigorously designed study that amongst individuals that did not receive anything, the percent abstinent, right, was really low in the group of individuals that did not get injectable buprenorphine. Percent abstinence was about 50%, right? So again, these medicines reduce use, but we know that reduced use is associated with reduced harms of substance use. Here is some pharmacokinetic data showing the mean buprenorphine plasma concentrations in those that got the 300 dose initially, followed by the 300 milligram dose at subsequently monthly injections. And for those that got the 300 milligram dose initially, and then the 100 milligram dose at subsequent injections. And so what you see is that the mean plasma concentration varies a little depending on how this is administered. And there is also some peak and troughs, which is why even in our patients who are getting injectable buprenorphine, we do tend to continue to monitor the symptoms that we expect injectable buprenorphine to control. So specifically withdrawal and cravings. And if patients continue to have symptoms of withdrawal and cravings, we are able to give them additional sublingual buprenorphine to keep them feeling well so that they do not return to use. And I think this is probably one of the most impactful points about using these medications. Here is data looking at mortality risk in those in buprenorphine treatment versus those that are not in treatment, and over greater than 2 times 2 increase in mortality in those that are not in buprenorphine treatment versus in those that are not versus those that are in. We see similar data, which is even stronger in some ways for methadone, where patients who are on methadone are less likely to die compared to those who are not. I'm going to switch gears a little bit and talk about injectable release naltrexone for alcohol use disorder. We do see quite a bit of alcohol use in our patients, and there are medications that are shown to be effective. Here is data from a randomized controlled trial looking at 2 different doses. The higher dose in the triangles at 380 milligrams, which is what we use in clinical practice, the 190 milligram dose, which was studied, and then patients that got placebo. So these were patients that were inpatient and abstinent at the time of initiation of extended release naltrexone. And again, you see that not everyone remains abstinent, but patients that are getting these evidence-based interventions are more likely to remain abstinent. And that abstinence does translate to improved infectious disease outcomes. Here is a study led by Sandy Springer at Yale, where they recruited patients who had alcohol use disorders and HIV infection prior to release from incarceration, and received a dose of injectable naltrexone. So you see amongst the placebo arm, rates of viral suppression at release baseline compared to 6 months were significantly lower, whereas amongst those in the injectable naltrexone arm, if you looked at rates of viral suppression at baseline versus 6 months, we see a significant increase in HIV viral suppression. And so we see the impact of these medications not only in reducing substance use, but then in really important clinical outcomes of improvement in HIV viral suppression and reduction in mortality. With regards to our patients at JHH, all of us have been around long enough to know that substances impact the health and lives of our patients. Data from the MORE cohort suggests that the prior 6-month substance use disorder prevalence in our clinic is 12% with heroin, 5% other opiates, 14% cocaine, and 13% hazardous alcohol use. There was a brief pilot done using a tool to assess both substance use and mental health disorder prevalence. And that tool suggested in a small cohort of about 250 patients that the prevalence of both substance use disorder and mental health disorder was as high as 46%. And when we think about our patients in the inpatient setting requiring outpatient antibiotic therapy, about 20% of these patients have substance use disorders. So a large proportion of our patients with substance use disorders driving negative infectious disease outcomes with potential to improve those outcomes. I'm now going to hand it over to Tracy to talk about some of the resources for substance use disorder care and how we use those resources. Over to you, Tracy.
Hello. Thank you so much. So, as Seun has said, and as you all know, in Bartlett, we're really on the front lines of this crisis every day, and we witness enormous suffering, but we do have tools to respond. Screening for symptoms of anxiety, depression, and substance use is now a routine part of rooming and helpful as a prompt to identify mental health and substance use disorders. We can prioritize identification of opioid use and other substance use disorders as well, but opioid use in particular as an urgent problem requiring immediate treatment. Risk for overdose, disability, or death is high in this era of fentanyl, and known contamination of street drugs with veterinary sedative medications like xylazine and other nitazines. that cause respiratory depression and bradycardia. So talk with your patients about opioid and alcohol use disorders being chronic diseases and those people with them deserving of life-saving treatment. In this chronic disease framework, our messaging goal is to communicate in a way that sets people up for healthier outcomes. Disease is not destiny, change can happen. Substance use disorders require ongoing treatment, dedication, and support, often using multiple modalities over an extended period of time. Patients can take control of their lives and must themselves accept responsibility for making changes. But when we say take responsibility, it doesn't simply mean stop using, or as they often hear, I got to get my act together. Instead, encourage them to show up for appointments, say yes to medications, yes to the support that is offered. Shame and guilt are not helpful motivators for long-term sustained change. There's no recommended time limit for pharmacological treatment with buprenorphine. You don't need to have addiction counseling services in order to provide bup. Psychosocial needs should, of course, be assessed and patients offered and referred to treatment based on their individual needs. But a patient's decision to decline psychosocial engagement or that referral to psychiatry should not preclude or delay medication treatment. So advise your patient to take medications, and again, focusing on opioid use disorder here, express a high level of concern for injury or death. You can reach out to the Restore navigator or counselor, Warren or Hope, for support. The navigator will meet the patient in real time, facilitate an appointment with the Restore provider, and coach the patient through safe initiation of sublingual bup now. If you have questions about the nuts and bolts of initiating or sustaining treatment, you can reach out via Epic Chat to me, Lee Gilman, who does a ton of this as part of his regular practice, but also for Restore, or Seun. Several of your clinic colleagues are facile with this process and include substance use disorder treatment as part of their primary care practices. Julie MacArthur, Amanda Rosecrans, Liz Gilliams, to name a few. They're all in clinic often, so curbside them. It can be a real asset and support of patients' recovery journey to have the care and management come from someone they already have worked with and developed trust in as their primary care provider. Restore services are available to partner with you in managing alcohol and opioid use disorders. All patients are eligible. They get linkage and retention services from our peer recovery support specialists. The peers receive pretty intensive clinical supervision to support the medical plans and to help partner with patients and providers in the whole healthcare system. For Restore, the core priorities are medications to treat opioid and alcohol use, engagement in available medical care and clinic services, and to really leverage the power of social support from trusted persons. The peer navigator and addictions counselor are really the secret sauce. They're the ones who keep the thread of treatment and messaging consistent between scheduled Bartlett appointments. They also provide harm reduction messaging, including explicitly discussing overdose response, a supply of Narcan readily available, don't use alone or behind closed or locked doors, ask people to administer Narcan and call 911 for you if you do overdose, and counsel people to agree to transport to the hospital when advised by EMS. I think everyone in clinic is now really aware of and experienced with the power of peer recovery specialists and the services and support they can provide. I want to highlight that they all adhere to core competencies of their certification in ethical responsibility, advocacy, mentoring, education, recovery, and wellness. So just to outline again for everybody here, we have a peer navigator, addictions counselor, weekly recovery groups on Wednesdays at 1:30, weekly treatment team meetings with consulting psychiatrist Dr. Jeff Shu and therapist Nicholas Schweitzer, Bartlett clinicians with dedicated time to see Bartlett patients with active or severe substance use disorders, Lee Gilman and myself, and all Bartlett providers are supported to provide medications. Emphasizing again to not delay treatment initiation to the next available Restore new patient appointment, especially for opioid use disorder. A word about tox screens. We order the pain rehab toxicology screening for the broadest testing available, including the presence of buprenorphine and its metabolites, which indicate use of the medication as prescribed, as well as xylazine. And we use these as a guide in our clinical decision-making. They're not meant to catch our patient doing something bad. The presence of illicit opioids is not a reason to discontinue buprenorphine. The presence of bupe is actually protective against overdose. Ongoing use of any substances, including alcohol, might be a reason to intensify psychosocial treatment or even refer to a higher level of care. And that piece can get kind of tricky because sometimes when we refer to that higher level of care, it's actually a referral to no care at all. So work closely with that patient and try to understand if the treatment's not working, think really carefully through the referral to a higher level of care and consider retaining them, even if the treatment response is not optimal. So I want to share with you this first case, highlighting management of opioid use disorder in the context of both acute and chronic pain. This is a longtime primary care patient in Bartlett, previously in the Moore Clinic, with an excellent relationship with her primary care physician. She has HIV, hepatitis C post-cure, depression, anxiety, bipolar disorder, and cigarette use. She also has coronary artery disease, chronic kidney disease, cardiomyopathy, and hypertension. She has good social support in 5 adult children and also some grandchildren, but she's the full-time caretaker of her disabled husband. She began first using substances at the age of 15, injecting opioids by 23. She had a very long period of full remission of 10 years, which ended with her husband's disability onset in February of 2019. Cigarette use since a teen and using 7 cigarettes per day when we first meet her. Let's see, hang on just one second. I got a blip on my screen, forgive me. Thank you. So when we first meet her, it's August of 2022 when she's admitted to the hospital for a substance use related fall, resulting in pneumothorax and multiple rib fractures. She started on buprenorphine naltrexone during the hospitalization and discharged to Bartlett and Restore. It had been 2 years since she'd seen her primary care physician. We continued the Suboxone, started Restore support services, but in October, she had community-acquired pneumonia and was rehospitalized. So when we finally really start getting to work with her, we learned that she is mostly concerned about her rib pain, discomfort with movement, and her breathing is restricted, and she's really frustrated and angry with her caretaker role, especially now that she's unwell. She has great facilitators, her faith, her family. She tells us she's never going back to use, and that fall was a wake-up call. And this, I want to highlight here that she has really good control of HIV viremia and a great CD4 count. And that's an opportunity, we took that opportunity to highlight her investment in her own health. So, which approach has the highest likelihood of success for Ms. Number One's opioid use disorder? She's complicated and fragile. We should refer her to an outside opioid treatment program, or OTP, previously known as methadone treatment programs. Due to pain, she needs methadone instead of buprenorphine, which we cannot provide in the outpatient setting. Should we intensify her opioid use disorder treatment and pain management in our outpatient office setting? Engage available clinic supports or refer her to residential treatment outside of Baltimore? So we chose C and D to intensify her treatment in our office setting and engage in available clinic supports. We did not want to refer her outside of the city because of her medical needs, but also because she had such strong support in her family. So the treatment team met, and our plan was to provide her with weekly and then every other week treatment with the Restore nurse practitioner. She received buprenorphine in divided doses at 24 milligrams a day, which covered both some pain management and her opioid use disorder treatment, and cigarette use management counseling, especially in the setting of her cardiovascular disease. She got weekly phone calls from the peer navigator and appointment reminders, and she had a lot of appointments, a lot of specialist appointments, and weekly Restore group support, met one-on-one every week with the addictions counselor. And we tried to engage psychiatry, but she declined. Her response to treatment was great. Her opioid use disorder remained in remission. She adhered to all of her appointments, attended all of the scheduled groups and one-on-ones, and she managed to reduce her cigarette use to less than 5 a day, which she would have when she drank her coffee. We gradually reduced the intensity of her support to monthly with me, weekly groups, intermittent recovery from the peer navigator, and one-on-one with the ADT counselor as well, the addictions counselor. So she proceeded to do well, but in June of 23, she witnessed the really violent death of her husband in their home. In this period of time, she had increased anxiety and depression, along with forgetfulness with medication refills. And so we again intensified her support, and her opioid use disorder remained in remission. In March of this year, she was hospitalized with a cerebellar stroke and right carotid artery stenosis with hemiparesis, cognitive deficits, and acute pain with a rib fracture. While she was there, she had a consult with the addiction service, and they initiated opioid analgesic, which we continued outside. And I want to use this case to really highlight this treatment of acute pain in a patient with OUD. And that includes continuation of buprenorphine and use of a multimodal regimen to target pain via multiple mechanisms, where use of some agents like NSAIDs are limited by other medical morbidities, and this is a patient with chronic kidney disease, and as non-opioid analgesics are often insufficient to manage acute pain, it's really reasonable in this setting to use an opioid analgesic with the expectation that these can be tapered off or discontinued once the pain improves. Continuing the buprenorphine beneath that will improve the tolerability of the taper when it's time, and provide a degree of long-acting analgesia alongside the other medications. So her acute pain was managed by both taking her sublingual bupe in divided doses and the addition of oxycodone through a period of acute pain for the rib fracture. And she used that oxycodone really judiciously. She persisted valiantly with physical therapy and occupational therapy, and her rib pain resolved. The analgesia was discontinued. However, she began complaining of low back pain that was not troublesome during physical therapy, but really hard for her to manage when she was home, and asked for the oxycodone to be extended for chronic low back pain, which is not indicated. It was really frustrating to her, and there was a high level of concern from all of us on the Restore team, her Bartlett physician and nurse, and the physical therapy team and the patient herself that she might relapse to fentanyl use. So we worked really hard together and provided really consistent and supportive messaging regarding physical therapy, use of pain psychiatry as the best plan for treating her chronic pain. And we did continue her with the divided doses of bupe. She was ultimately accepting of this and continues to engage in multidisciplinary care with her opioid use disorder remaining in remission. And so this was a really great case for me, and I was terrified that she was going to drop out of care, and she threatened to drop out of care. And we all really held the same message, and she ultimately came back, and I'll never forget this. And actually, Priyal Gandhi's on the call, and she was in the room when this was said, and she sat down one day, and it's a month after kind of the big part of this, and she sat down and she looked at me and she said, "I was really mad at you, but I still love you." And that was the same message she gave to her primary care physician and others on the team, that like, you guys stuck it out with me. So you'll recall bupe is a partial opioid agonist. Other opioids like fentanyl, heroin, oxycodone, methadone, those are all full agonists, right? And bupe has a higher binding affinity for the mu opioid receptor that dissipates after 24 to 72 hours. So it thus blocks other opioids from binding and can prevent or mitigate the degree of injury from opioid overdose. And I'm taking the time to point this out. I know this is stuff you guys know, because this medication is useful for our patients whose opioid use disorder is not in remission. The presence of an illicitly used opioid like fentanyl in a tox screen is therefore not a reason to discontinue prescribing, so long as the person is taking it. Bartlett providers have started using extended release bupe. We just had a great presentation Wednesday about some of the finer points of its use in our learning collaborative, and I'll provide a link to that recording in our chat later. Sublocade is the preparation we have available to us right now. We'll soon have Brixadi as well. But for Sublocade, a person should have already undergone induction to sublingual bupe. A few helpful tips. It's an order you put in without selecting any pharmacy. You choose the order with the bed icon next to it, and you'll see that it indicates clinic administered RX in red. So once you've ordered it, I'm sorry, my apologies. Let me get my slides back.
Tracy, not to distract you while you're pulling up your slides, but I
Yeah,
think,
okay.
you know, that was such a beautiful story. And it strikes me that the reason why you were able to walk through that period was because of a consistent and team delivered message. I just wondered if that resonated with you, or if like, do you think that,
Yeah. That was the most important take home to me, was it wasn't the Restore team, it wasn't one person. It was the fact that we worked collaboratively, and now I am distracted. Here we go. I'm so sorry, you guys. I don't know what happened to my computer. It was the fact of working collaboratively and making sure that everybody had the same message, because she was talking to all of us about it, right? There we go. I think this is where we should be. But I don't know what screen. Yeah, so she was really, which screen do you guys see? Do you see the full slide?
no, we don't see the full slide yet.
I'm so sorry.
Don't worry. This is like, it's like 45 seconds. It feels like forever, but this
That's
happens to
really
me frequently. And when
forever.
you actually measure the time, it's very short. It feels like forever. There you go. Perfect.
Yeah, so the big message with her was that, you know, she was talking to all these different people involved in her care, her nurse, her primary care doc, the PT team, and everybody was really scared and worked up. But when we got together and really talked through her care and agreed on a set of messaging, I think even though she's not happy with what we decided, because she wants her pain gone, right? It's terrible. But she does believe that we chose the best possible treatment course and that we have her back collectively. And I think that made her feel safe too. All right, can you guys see the right screen? Okay, so going back to prescribing extended release bupe away from that particular case, once you've ordered it as the bed, you're going to send a chat to the JHH ambulatory pharmacy, AIMS, to their group chat. So if you put this in regular people, it doesn't pop up, but in groups it does. Include Abigail Taggart in that, and let them know the date of the anticipated administration of a Sublocade. And she'll pick up, Abigail's amazing. She's been picking up from AIMS on Fridays for us, and stores the medication in the clinic Pyxis. Your nurse can pull this for you when your patient arrives. The way we have it set up right now is that the physician or APP gives the first 300 milligram subcutaneous dose, and Abigail's happy to give the subsequent doses. She has dedicated slots on Mondays. It's helped a lot in the flow of doing this. Once you've given it, you're going to scan, or before you give it, or once you give it, on the box there's a barcode. Make sure you scan that barcode. We're not all used to doing that. Enter the details about administering. You can use a couple of smart phrases. They both start with Sublocade, so Sublocade patient instructions and Sublocade admin restore for your progress note. Follow up with a check-in, order your next doses before. And again, you know, Lee Gilman and I are really happy to be the ones following people, especially through their really acute period. And you can leverage our peer recovery specialist, Warren Lee. to get them in with us, but if there's not an opening right away, please don't delay treatment. So let's switch gears and talk about alcohol use. I have about 9 minutes. As noted by Seun earlier, we see many unintended consequences of alcohol use and alcohol use disorder in Bartlett, notably presenting as uncontrolled HIV. Injury, physical and sexual assault, carceral involvement, risky behaviors, sexually transmitted infections, and long-term consequences such as cardiovascular disease, pancreatitis, kidney disease, cancers, mood disorders. While legal, harm caused by alcohol use is pervasive. We all ask our patients about whether or not they drink. They often hear us asking whether or not they're an alcoholic. And so asking people to quantify and describe their intake may yield more useful information. I really like the way Canada's newly released guidance on alcohol and health frames alcohol use. Their guidance provides evidence-based advice on alcohol to support people in making informed decisions about their health. It's based on latest research on alcohol-related risks and replaces Canada's low-risk drinking guidelines issued in 2011. The guidance is based on the principle of autonomy and harm reduction, and the fundamental idea behind it is that people have a right to know that all alcohol use comes with risk. And they highlight in their guidance that consuming more than 2 standard drinks per occasion is associated with an increased risk of harm to self and others, including injuries and violence. And no matter where you are on the continuum, for your health, less alcohol is better. We're of course familiar with the NIAAA risk stratification, where risky use is defined as greater than 4 drinks for a man or greater than 3 for a woman on a single day, or greater than 14 drinks for a man or greater than 7 for a woman in a week. Once we identify alcohol use disorders in our patients, and as with opioid use disorder, we can offer support and treatment, and it works. The evidence-based medication we use a lot of in Bartlett is long-acting naltrexone, called Vivitrol. So I have a case that we presented a few years ago that I'd like to give you an update on, and I'll review the initial case first. This was a young person with really severe alcohol use disorder and depression. They came to us for help, motivated to gain clearance for surgical removal of anal condyloma. The surgeon didn't feel it was safe to proceed given elevated risk with endoscopy findings of esophageal erythema, punctate hemorrhages, duodenitis, and labs indicating transaminitis and concern for decreased liver synthetic function. When they first engaged with Restore, they had the hallmark of depression and alcohol use disorder that we see in Bartlett, a very low CD4 count of 6, and HIV viremia. So they were on multivitamin, Bactrim, Biktarvy, fluticasone, albuterol, promethazine, but were not taking fluoxetine or olanzapine. They'd been really, really close with their mother, with whom they lived, but she was recently deceased. They had a pet dog, but otherwise lived alone and socially really isolated. And that's, of course, this other epidemic that's sitting heavily on all of our patients, or most of them. At the time, they were drinking at least 1 pint of vodka per day with consistent blackouts and daily marijuana use, but no other drug use. So for Mr. 3, would you refer them to hospice? Not much more you can do. This person's headed all the way down. Explore their goals for their health, explore potential options for alcohol use disorder treatment, or refer to psychiatry. And you already know, we used a combination of last 3. We're not going to give up on anybody. So this person identified their biggest goal is surgery, stating their doctor would not perform the surgery because his liver was so sick. They want to reduce their intake, but is not interested in quitting alcohol, really upfront about that. But they agreed to medically supervised alcohol detoxification inpatient. They were linked to peer recovery support services, prescribed oral naltrexone at the time of detox. And then once they got to us right after, and we try to get people in the day they're discharged. So they come from there to us and we try to coordinate initiation of the extended release naltrexone. It's the same medication. Injectable seems to be a bit more efficacious, and whether that's an adherence issue or otherwise, I'm not sure. I don't have the answer to that. I'm not sure anybody does. So we started that with the initial plan for every 28 days. Our patient shared with us, I'm not trying to quit all the way, but the Vivitrol, is helping me slow down tremendously. I don't wake up craving a drink. I like that feeling of not needing it. They worked really hard to avoid downtime, trying to keep busy, distract themselves. They really felt a craving for their alcohol drop, especially noticeable in the first and second weeks after administration of Vivitrol. And so we changed their dosing to every 21 days, which you can do with Vivitrol, because of this increased craving that really peaked at the end of the third week. Also notable, although this was not the case for this person, abstinence is not necessary prior to initiating, but the detox and then initiation is thought to be more efficacious. So 60 days later, we're still back in 2021. They had re-engaged with psychiatry, took on a delivery job. My memory is that they were also going to the Y and really loving that. Decreased alcohol intake to even some days of full abstinence. Really exciting, their viremia became controlled and their CD4 count bumped up to 98 from 6. Transaminases normalized, liver synthetic function restored. And they, at that point, this is where we stopped in our presentation with you before, they were continuing to engage with us. So here's our update, and this is fun. In December of 21, they received their desired surgery with resolution of the transaminitis and the liver synthetic function improvement, continued to see restore, their HIV primary care physician, their nurse, and psychiatry, continued to drink smaller amounts of alcohol, was never fully abstinent of alcohol. So between March of 21 and July of 22, they continued Vivitrol monthly, but with a period of increased depression and alcohol, resumed drinking, and was kind of lost to care for a little while. But with the help, I'm speeding up because I have 2 minutes. With the help of their physician and their nurse, they started Vivitrol again in 2023. Were randomized to intervention with Prosper in June and re-engaged with a psychiatric nurse practitioner. And you know, this is somebody who in 2021, their liver was looking pretty junky and their CD4 count was 6. And currently their CD4 count is 229 and they've maintained virologic suppression. Vivitrol stocked in our Pyxis. The CMAs can administer it. We order it as a 28-day medication, and it can be given every 21 to 28 days, depending on patient response to treatment. And I get to hand it back to you now, Seun. Thank you.
Thank you, Tracy, for that amazing description of all the amazing work that you are leading with the Restore team at Bartlett. I'm going to end now with some of the new directions that we're taking with the work to further improve our ability to improve health outcomes for our patients. So I know folks have seen this slide where we show, this is kind of a summary of the individual cases that Tracy presented, where we see that with Restore, we see improvement in substance use across all substances. We see reductions in ED visits and hospitalizations. And we see increases in HIV viral suppression and hepatitis C care that are statistically significant. Across the COVID pandemic, in a paper led by Drew Park, we saw high retention in the program at a time when many patients were dropping out of care, and we saw reduction in overdose rates. While we had improvements in symptoms of anxiety as measured by the GAD-7, we really did not see a significant reduction in depression. And this remains important because we know that mental health disorders are common in our patients who are living with substance use disorders, and mental health disorders negatively impact HIV outcomes. This is data by a paper led by Tafa Berinumbe, postdoctoral fellow on my team, looking at patients who had been in Bartlett pre and post the COVID pandemic, and then looking at what happened with their depressive symptoms in that time frame. And what you see is that in patients who had worsening in their depressive symptoms, they were significantly more likely to be virally non-suppressed than patients that remained non-depressed. So depression clearly is driving HIV viral load non-suppression in our cohort. I'm trying to take what we learned from Restore about the importance of a team and our lack of effect on depression. We were fortunate to get this NIH NIDA grant, which is using a hybrid type 1 implementation effectiveness evaluation of an adapted collaborative care model. The collaborative care model is evidence-based. It's endorsed by the American Psychiatric Association and usually has behavioral specialists, very often a nurse or a social worker, being the person that helps to keep the team together. In our adaptation, we're using a peer specialist as a peer coach. And so to assess this evidence-based intervention, we did a couple of things. We have worked to enhance screening for substance use in our clinic. Shout out to Sheila and all the MAs that have implemented routine screening using the PHQ-2, GAT2, and the NIDA quick screen. And we also have worked to try to help providers become aware by sending notes when patients screen positive. In addition, the MAs also have been trained to make providers aware when patients have a GAT2 or a PHQ-2 above the cutoff of 3. And the hope is that with increased screening and treatment, we will see improvement in rates of HIV viral suppression and care engagement. But more importantly, there's no use to an intervention if it does not fit into the workflow, if it does not fit into the way we provide care. And so as part of this study, we're going to be assessing implementation outcomes of adoption, acceptability, workflow integration. A key part of this intervention is that the patient is surrounded by a team that is providing the same messaging to the patient. And the way we do this is that we have, for people that are randomized to the intervention arm, they are given a peer coach who works to engage with the patient. And this really involves using, shared experience and a shared understanding of what it means to be in that position to develop a meaningful relationship. In addition, the peer coach uses validated surveys to collect information about the patient's mental health and substance use. That information is entered into a secure registry that our consultant addiction psychiatrist, Jeff Shu, reviews every week with the peers. Using that information, he puts recommendations in the EMR that go to the patient's HIV provider. And in particular, he's very good about sending EMR notes when he recommends initiation of medications, either for anxiety, depression, or substance use disorders. And the hope is that because our consultant addiction psychiatrist is someone that is well known, if providers have any questions about the recommendations he's making or any concerns about the patients, they feel comfortable asking those questions so that over time, we are able to integrate mental health and substance use disorder care into HIV care. As you've seen, many of our patients, although they have access to psychiatry in the clinic, very often they do not want to go to the psychiatrist because they already have a trusting relationship with their HIV provider. The peers are using a protocolized, manualized intervention to support the patients. This intervention was developed by Heidi Houghton, who was a clinical psychologist in the clinic for many years, and uses a number of evidence-based tools, goal setting, some cognitive-based therapy, and motivational interviewing, and to really help patients identify how substance use or their mental health might be impacting their health or lives, develop goals that are meaningful to them, and then work towards achieving these goals. Patients are also taught coping strategies like finger breathing, the 3 Ds, delay, discuss, or do something to both address substance use and mental health. We continue to recruit patients in the clinic. I have to shout out to the amazing Prosper team that have been working hard to recruit participants. Please, if you have any patients that you think might benefit from mental health or substance use disorder care support, please reach out to Lily, Grace, Meredith. You will also potentially hear from Anis as we move forward with our qualitative interviews, where we really want to get an honest understanding of what works about this intervention and what could be done better. I want to talk a little briefly about our other patients in the inpatient setting who have serious infectious diseases that are driven by substance use. We have a team of peers through a SAMHSA-funded grant called Support to Restore, who are available to engage with patients in the inpatient setting and support them as they transition to the outpatient setting. Very fortunate to partner with Megan Buresh and Sarah Keller on this work. The peers provide ongoing support in the community for up to 12 months and will help with everything from how do I figure out ongoing substance use disorder care in the community to I don't have my follow-up ID appointment, how do I get it, to I lost housing, how do I navigate housing. There are lots of resources out there for those that want to learn more about substance use disorder care. And for those that would like to figure out sending patients, I'm so sorry. The supports, so lots of resources out there. If you're interested in doing more injectable buprenorphine, additionally, lots of resources. If you want to refer those patients to Restore, please refer the patients to Restore. The goal is to make sure that our patients have access to the care they need. And we also have the Support to Restore learning collaboratives. The goal of Support to Restore is really to reduce overdose deaths across the state of Maryland by providing supports both to providers and patients. So for the patients, we have the peers who I just described. For the providers, we have these learning collaboratives, which we have every 2 months. We had one on use of long-acting buprenorphine on Wednesday. These are very pragmatic presentations, really focused on the how-to of doing these things, and really helpful for providers that want to figure out how to integrate this into their care. And we've had talks on nicotine addiction, medications for stimulant use disorders, managing pain in opioid use disorder, transitions and approaches to first-person care in opioid use disorder treatment. If you would like to be added to the listserv, you can email Maria or email Tracy and I, and we also have all the recordings. I think Tracy will put a chat so that you can access any of these recordings. To make referrals, we now have Epic group chats. There's one for Bartlett Restore for patients in our Bartlett clinic, and then Support to Restore for patients outside the Bartlett clinic. In summary, I hope we are even more sensitized to how opioid use disorder is life-threatening and requires urgent treatment. And substance use disorders negatively impact health outcomes for our patients. They are chronic, but I think very important, they are treatable, and all of us are in a position to provide this treatment. We are very fortunate to have the opportunity to work together to optimize infectious disease care needs by meeting the substance use disorder care needs of our patients. And I think all of us are well positioned to do this, and lots of supports to do this, and really looking for additional feedback on how we can support these programs and the care for our patients even more. Thank you so much. We try to leave time for questions, but well, this is what we have.
Well, thank you both so much, and to the whole team. It's really great to see many of the faces that are otherwise faces on Epic Chats. So thank you all for being here. I mean, I think as speaking of someone who does, I saw one of our Restore hasn't quite been fully lassoed in yet patients on Monday, and was able to re-prescribe his buprenorphine, and then also immediately Warren touched base with him, and that team approach, I think, is just the only way that many of these patients will walk through that. So thank you so much for all that you're doing. I think one topic in in particular, I'd just love to hear a comment on is I've had a couple of patients recently where meth is the primary challenge, and just wondering how that's not really fitting in with the sort of like main scope of the program and suggestions about how to reach out. I mean, Tracy, I think, was reached out to about a patient with a similar issue, with this issue recently. And so if either one of you want to comment on that, that would be super helpful.
Yeah, I would start by saying that we share your frustration, Eileen. One of the learning collaboratives is on treatment of stimulant use disorders. Because we don't have evidence-based medication interventions that are as responsive as alcohol and opioid use disorders, and because of our limited bandwidth, we are focused more on the opioid and alcohol use disorders. That said, we recognize that cocaine and methamphetamine use are incredibly dangerous, right? We're seeing all these patients who end up on dialysis and all other kinds of problems. And so it's not for lack of understanding the severity of the illness, but trying to make sure we optimize the amount of capacity we have in the clinic right now. Our peers and counselors, we have folks with stimulant use disorders in our group who receive one-on-one counseling, who are referred to available support groups in the community that specialize in stimulant use disorders. The only stimulant use disorder treatment program that's available is currently taking private insurance only. That's a local residential program. And so this is something we, as a team, we've been talking about a lot, and stay tuned. We want to be able to do something more than what we're doing.
Yeah, I mean, we've talked about contingency management and ways to implement it.
Yeah.
But it's work.
Yeah.
We have to figure out how to do so that we can sustain it systematically. Yeah.
Perfect. Any other questions from the group? We have about a minute left. There's a bunch of people saying how amazing you guys are in the chat.
I want to call out Lee Gilman for really tireless expert substance use disorder intervention as part of his HIV and hepatitis C practice, and also his work on the van in the community. I feel so lucky to have him as my close colleague. And Lee, if you have anything you want to add at all, please do, but I don't mean to put you on the spot. But we're really lucky to have him in clinic.
And so fortunate to have such a strong team, our peers, the addiction counselors, and thank you for the opportunity. We would love referrals to Prosper. Lily, Meredith, and I think Tafa on the call. Can you guys each say hello, a quick hello, so they see your faces, so they know they can refer patients to you?
Hello. Hello.
It's Lily.
Hello.
That's Tafa.
Okay. Great. And I also want to just take one moment of just to reflect on how incredibly thankful we are for all of the efforts from the Restore team in gathering data, and Joyce and Allison and others for advocating for continued support from the hospital for this program.
Yeah.
Because this would be a very different conference if we did not have that sustaining support. So thank you to all of you for the work that you do. It's absolutely critical for our patients and makes it a much more satisfying place to practice. And we will put up any slides that are available, will be available on the Teams. And then also, I think maybe if we can get some of the referral information into the intranet so that people can have that as a landing space to find those sort of workflows for some of the interventions like long-acting injectable medications. So thank you so much. And thanks everyone for joining today, and have a wonderful July 4th. And we'll see you back in the second week of July.
Thank you.
Thanks, everybody.